Hello everyone. So after discussing about cost, production and before that supply and demand, we'll try to give you some understanding about the empirical or the theoretical perspectives of market demand or individual demand, especially in terms of healthcare. So, the very fundamental economic theory based on consumers' demand was given by, which is particularly or especially connected to the healthcare models, was first given by Grossman in the year of 1972, where he basically talked that individual actually don't demand health care, but they demand health stock. Actually, they are the producer of health stock. Not only they demand health stock through healthcare, but they are producer of the health stock. So that was given by Grossman in the year of 1972. We will discuss about this after a certain while, and where he talks about that health is basically health stock here, which is my productive resources, or productive investment. So I invest for health stock. On the other hand, when I look at the Cropper's theory of healthcare demand, which was given in the year of 1977, it was basically extended over Grossman's model, and extension over Grossman's model. And here he took it to the utility theory, where the or utility maximization framework, where he basically talks that individuals' demand for health stock is generally determined by the preventive and curative care they will require based on their health status over the life cycle, and this will differ from individual to individual, and then hence the demand curve or the indifference curve both will differ from individual to individual. So in both these cases we are actually looking at utility maximization framework, or utility maximizing framework. Yes, so individual may have preference for health directly. So preference for, or I will say direct preference for health, or it can come through as the individual demand health service, which is as an input, that health service as an input of health status. So they are not basically demanding or preferring some health care or some health outcome or some health service. They are preferring health service as a function or as an input of the health status, number one. And then this health status will be determined by the individual preference for health. Now, a sick person's individual preference for health will be different than a healthy person, and the sick person's demand for health service as an input towards their health status, towards their improvement of health status, will be different than that of the sick person. So they will demand the health service as an input of health status, and this health input of health status, the demand for the input of health status will differ from individual to individual as a preference for health service, and it will change with the onset of diseases. Now a sick person, a healthy person falls sick, immediately their demand for health service will be different than he was having when he was healthy. So it is very relative. The next thing what we have to keep in mind when we demand for health service are ample number of choices. Choices of whether you will go to a hospital, choices of whether you will go to a clinic, or it's a traditional medicine practice, or traditional medicine, or home-based remedies. And these choices will also be differ from disease to disease, across different socio-economic variables or socio-economic characteristics. By the income status, rural and urban, education, age, marital status, so on and so forth. And at the same time, such demand pattern, once it is studied properly, will help the policymakers to identify the pathways to target those particular those particular morbidities in a particular area, in a particular time period, and the behavioral aspects of the community towards that particular disease, and how to track that, how to improve the scenario. So studying such demand patterns will help policymakers to design state specific. Now this state can be in several ways, it can be the health status, it can be the societal status, it can be the state by the word geographical political boundary. So design state specific policies or strategies. Yes, therefore when we talk about individual preference to have a health care or health status or health stock, whatever, or to avail a health service, individual preference, and when both Grossman and Cropper have started their has propounded their theories based on utility maximization framework, then we can place the utility maximization theory as a function, or my utility is actually derived from C and H. C is the consumption for any other commodities, H is the health consumption towards health or health status. Yes, if I draw, it will be a two commodity framework where over here C, over here H, this being my budget and budget constraint, and I have several indifference curves. And I have different choices, I have different choices, as we learned that given my budget, what will be my different choices between consumption of other commodities and health services or health care or health status. You can eventually substitute it as either H for health status, or small s or H small s as health services, whichever way, it can be, this graphical plot can be shown in both the ways simultaneously. The problem we always have faced, that whether health can be can be quantified as a discrete variable, as a single unit or something. So there has not been a very convincing answer ever, but we have tried several proxy measures, we have tried several direct measures, but not all the health variables, health related variables can be easily quantifiable. Then the economic theories have faced little trouble, and the questions have arised based on that how could you estimate health status. Now, in terms of production, because again Grossman and Cropper talks individuals are the producer of their own health stock, they invest on their health. So if we are talking about this health as in the production function, then we can write our production function as H, which is my health stock, or you can keep it capital H, whichever you want to keep it, as a function of medical care, small m. You can keep your denotations. So I will write notations anyway. I can write this is my health stock and this is my medical care, or the investment on health, or investment on health. Right. So my health stock is dependent upon the how much I am investing on health. If I don't invest on health, naturally my my medical care will be poor. I mean my health stock will be poor, and it always has a decreasing return to scale, because when you invest more and more on your health to improve your health stock towards your health care, you won't require, after a certain while you are healthy, and even if you invest on that, you are not generating enough output in terms of your health stock, improvement in your health stock. So it has a decreasing marginal returns to scale. So it comes down, it's a downward sloping curve. Therefore it's a decreasing return to scale when scale is the investment in medical care or just investment. Okay. Now coming to the budget constraint again. Because over here we have talked about the utility, at this point we have talked about the utility, talking about the indifference curves, but over here we are talking about the budget constraint. So when we are talking about this budget constraint, this blue line, we have to think that we are actually investing on both C, that is consumption of other goods, as well as on H. Right? If I can think that M or is the expenditure on medical care, then we can keep our budget constraint as I if this is my income will be less than equal to, or sorry, will be greater than equal to C, consumption on other goods, plus M into H, which is expenditure on medical care. So this consumption of other goods plus expenditure on medical care again should be less than equals I. I is my total income or total budget constraint. It can be in terms of production, it can be in terms of, so in terms of production you can talk about the ISO cost line. If you are an individual producing your own health stock, if you are a consumer asking for your individual preference, then it is like your budget line, budget constraint. So this particular formula can be used in both the ways. So therefore, whenever my budget improves, if I go to this curve, I will keep it in the same this thing. So my income improves, so the budget line shifts outwards, and what happens to my preference? It also shifts outwards. So I can actually now over here, when I was producing this amount of C and H, this amount of C and H over here, C prime and H prime, now with more income I can demand both of C prime and H prime, I mean C double prime and H double prime maybe more. So I am consuming more other goods, I am consuming, I am asking for more healthcare, if healthcare is a normal good. So what does it mean normal good? So that means when generally income increases, you will ask for more of a particular commodity if that is a normal good. The contrary can be inferior good, which healthcare generally is not. Inferior good is when your income increases, you will demand for the less of that particular commodity. Your income increases, the demand for that commodity declines. So it is kind of an inferior good. Before going there, I will just we will move to the income and this price effect, that how it happens when the it's a in terms of income expansion curve. But before that, I would like to give you two different diagrams that when the individual preference or budget set changes when I am ill or I am not ill. So if I can show you in again a diagrammatic framework, and then if this is my C and this is my H and this is my first demand curve, when the budget line, when the individual is healthy. So this is my budget line. So what happens when the and I can draw my indifference curve over here. This is my indifference curve. Maybe I can write indifference curve healthy. What happens when the person falls sick? That means they are spending more on healthcare, or their income total budget constraint in a relative way can be shifted like this. It can be like this. It can also be like this. If they decline their consumption as well, if they don't, then it will start from this point. If they do, then it will decline, and it will because the expenditure has increased, so you can see the I by H will fall down and their indifference curve will shift. Yeah, so it's not that they are actually their relative consumption towards health has increased and their budget constraint has declined. That's primarily because they are not. Now we can take this example that they are not able to go to work, so they are losing their income. At the same time, the price of that particular the total expenditure, the price for 1 unit of healthcare what I will require when I am ill is increasing, right? Because I have to spend more, so it is shifting inside. So that is why you can see that there has been a shift or the more shift towards this. Yes, and the same way, if we were here having more of health, enjoying more of health and more of consumption, we are now enjoying less health and less consumption, and even though my total relative spending over health has increased. Anyways, now income and price effects. When we are discussing about income and price effects, we will discuss it over the income expansion curve. So how the price of a particular commodity changes and the income and it also changes with the income. So income and price effects, this price in terms of the health care, and we will take it through the income consumption curve, income expansion curve. And what it says that if it can be H, it can be S, health stock, or health status or health services, the demand for health services. It can be anywhere, or if I have 3 different levels of incomes. Yes, budget line 1, more income, budget line 2, more income, budget line 3. And with these respective incomes, I have different preference levels. and these preference levels can be stated as over here, and over here. So which gives me a an income expansion curve something like this. Yes, eventually if it declines like this, then this consumption good is an inferior good, because with the more of the income I am actually demanding less of the consumption good. If it moves like this, it bends like this, then health is an inferior good, because with more of the income I am demanding less of the health. But health is a normal good. We will always consider that health is a normal good. Therefore we are not going to the inferior commodity framework. So what happens over here, if the health bends, the income expansion curve bends towards this health axis, that means it's a luxury good. That with the more of income, the consumers are demanding more of health. Health is a luxury good. What happens if health is not the luxury good, if it's a necessity commodity? Then with the increase in income, my income expansion will be something like this. Yes, it is increasing. My income expansion curve, you can call it IEC, my income expansion curve, it is increasing, but at the same time what is happening here, it's a necessity good, or necessary commodity. Yes, it behaves normally, it doesn't, and you can think that consumption good is because the other consumption good may be very much important as compared to health. So they will, with the income, the proportion share of the budget will go towards more other consumption goods. Yes, but again it will differ from the health status, so this can be health services and health status and health services, the demand for health services. Anyways, so once we are, we are talking about this income and price effects, we have to decide that how price changes, which are the determinants of price. Before going to the determinants of price, there is a common concept in terms of healthcare which is known as user fee. User fee is the price what we generally pay when we go to a hospital for some consultation or to a clinic. That is the user fee. The payment we make, it's not the payment the insurance companies are making on behalf of us out of our health insurance. This is not that is not user fee if the insurance company or I am being paid by some health scheme. It is kind of an out of pocket expenditure. What the charges I am generally paying to avail my health services. That is user fee. Now, we generally think of price in terms of monetary payments. But as I said, that the dynamics changes completely if the government has a mechanism of subsidies or taxes. So if the government is giving subsidies for a particular, say the government is giving subsidies for an annual checkup for a certain group of people, you go for a health checkup and then the government gives subsidy. So naturally the demand of that particular commodity will increase. But at the same time, if government asks for additional taxes to utilize certain things, say that GST has increased the price of the cold drinks, or the more taxes levied on cigarettes, so the demand should fall down. You can think of them as a consumption good, but if you are thinking of certain commodities which is associated with health as well, but being levied with taxes, the demand for those healthy commodities, maybe the protein supplements. So people are moving out of the protein supplements, they are following a better diet, coming out of the floating supplement. So, so this payment mechanism, even though I am not paying that, directly or maybe indirectly, even though mostly if there is a tax we are paying for that, if it is a subsidy maybe the government is paying that, but the pricing is is changing, is varying, and there so does our demand. Apart from the subsidies and taxes, the second is the insurance. Whether certain aspects of my health care is covered by the insurance, and that changes the demand completely. We will talk about insurance for a lengthy session, during a lengthy session, but still, I mean, health insurance, this health insurance mechanism, if I think that cutting nails is also covered by health insurance, so I will go to visit a doctor and ask them, please cut my nails, because that is covered under health insurance. Or if certain, even if hospitalization is not required, but I will go for a hospitalization. That's because if I don't go for hospitalization, the entire money for that purpose, even if hospitalization is not required, I will go for hospitalization, because if I don't, then the entire money I have to pay. If I am going for the hospitalization, then the insurance company pays for me, and I pay a little amount which is much lesser than what I am otherwise paying, not choosing for hospitalization or one night stay in the hospital. So here the hospital is being benefited, I am also being benefited, but the pricing mechanism is harming that another industry, that is insurance industry. Anyways, but the health seeking behavior, the demand is completely changing based on what is being covered by insurance, or whether I have insurance or not, or what kind of insurance I do have. Okay, so and that is where the services also being rendered by the providers are also differing, that whether on a certain aspects, whether they are being subsidized by the government, or for some service delivery they are being taxed by the government, or some service delivery they are getting money from the insurance so that they can charge more. So the service delivery completely or largely changes based on these payment mechanisms. So, and this variation is very high in an in a market which is characterized by a high income inequality or socio-economic inequality, or a developing market where the insurance is not formalized completely, or the penetration towards most of the sections of the society is very low. And we have seen that more advanced economy, the percentage share from the GDP towards the health care has been very high. So that means the government is taking care of the health of its population. So the health seeking behavior is really improved. And what we learned in the first session, and many developing countries, the utilization rates of health care is pretty low, pertaining to that most of these payment are coming through out of pocket expenditure, making in terms of user fee and all. So it has been low. So there can be basically two reasons. So one is the quality of the medical care being poor, or the trust is not that strong. So the reasons why reasons for poor health seeking behavior in developing countries. A, or one, is quality of medical care is poor, or the accessibility is poor, and second, they are the patients may have to incur additional costs in terms of costs of travel and then all. Cost of travel, loss of income, travel, loss of income, because their health care is not being covered by themselves, by somebody others, and they have to cover it by themselves, so it is pretty high for them. And then the opportunity cost, which is like not being able to, you know, to be to productively invest their time, so they are losing their income as well. The another challenge in terms of the pricing mechanism, or in terms of the what comes from the costing mechanisms, in fact from the hospital or the healthcare providers, is healthcare is not basically, we cannot basically keep it under a single umbrella, calling it a single product, that healthcare or health status or health service. It's a, you know, accumulation of multiple goods, and these multiple goods often causes difficulty. These multiple goods, because the services are different, say the medicines are different, the doctors are different. One particular service may require different kinds of pathological diagnostic systems. The number of times, you know, that they need to visit the doctor, that requirement is different. The length of stay, average length of stay in a hospital, that is different, and everything together, and what kind of facilities they are going or they are visiting for their treatment, that is also different. So everything together actually is, you know, is billed under that particular treatment cost, and that multiple goods often, if not rightly collected, calculated or estimated, you know, causes a mistake in the pricing. So this multiple good, and once it is, you know, every component of these goods together, or every component of this health service can be differently priced, differently taxed, different, whether they are covered under insurance, whether they can be returned back, or how many, what is the percentage of the insurance coverage. So depending upon all these, the entire, you know, the payment from the patient is estimated, and which is not an easy task. Similarly, based on the quality, as the demand curve shifts, so the quality is better, the demand curve shifts outwards, because they want more and more of that better health quality treatment. If the quality is poor, then they don't really want to go for this health care. So the, you know, the health seeking behavior is poor, and then this demand curve comes down. So it's like that, you know, so it is just shifting. So the question is whether really higher quality determines the health care. If yes, which we generally find yes, then there is a requirement of policy intervention, because better the quality, better is the health intervention, I mean health seeking behavior, better is the health seeking behavior, better is health status, better is health status, better is the productivity, and it has a direct impact on the GDP of that particular country. So there is a you know, possibility of you know, policy intervention. So when we want to model this entire health economic these variables together, and model means, if we talk about this econometric modeling, regression equations, so on and so forth, we basically, you know, keep our dependent variable as healthcare demand, you know, and in terms of, it can be that what is my demand, what is the expenditure, can it really be estimated in terms of the expenditure I am making towards my health needs or health requirements. If that is so, and then which will be my independent variable if I am estimating you know, the demand curve or the demand framework on the demand status, then it will naturally be prices. Again, price being highly ambiguous, doesn't matter. And generally, if it works like that, then we can work it out on a simple ordinary list square where both the variables are continuous, and you know. So but while regressing, we must keep in mind that the overall heterogeneity in our healthcare system, when I'm trying to regress this or trying to get different demand curves, we always need to keep in mind what is the scenario, what is the status. Otherwise, I'm leading to an ambiguity given the complex structure of this entire healthcare system. I cannot really bring everything together under a same regression equation or a same econometric modeling. Thank you.